So before we start, I have a little bit of housekeeping. This presentation will be recorded for those of you who just came in. We will post at a later date on the Covenant Health YouTube channel. So if you don't want to be seen, feel free to change your name, your picture, anything you like at this point in time. We will address your questions at the end of the presentation. We do have somebody monitoring the questions, so if you think of a question throughout the presentation, please feel free to post in the chat, and then we'll go through those once Kathy and Dr. Chan have completed their presentations. And also an evaluation will be sent out immediately after this. So please feel free to fill out the evaluation and give us any more topics or ideas you may have for the future. Okay. In the spirit of reconciliation, we want to acknowledge that this gathering is taking place on traditional lands across the province of Alberta, home to many diverse Indigenous, Métis, and Inuit peoples. Spanning generations, acknowledgement of the land is a traditional custom of Indigenous peoples and an important part of reconciliation. It gives voice to the authentic history of the land and its original people. Honoring the land in this way acknowledges the story of the creation of this country in a way that has historically been missing. And credit to Kim Tackaberry. So to introduce our presenters today, Catherine Chan, PhD, is a professor of nutrition and physiology at the University of Alberta in Edmonton, as scientific director of the Diabetes, Obesity, and Nutrition Strategic Clinical Network of Alberta Health Services. From 2015 to 2020, she evaluated the impact of initiatives to reduce the impact of diabetic foot disease in Alberta. Dr. Chan has many research interests, including preclinical research on the healthful properties of whole foods or ingredients. She is also active in nutrition, clinical trials to improve diabetes outcomes and prevent complications. She has published over 150 peer-reviewed papers and co-authored the Nutrition Therapy Chapter 2018 and the Diabetes Remission Chapter in 2020, Diabetes Canada Clinical Practice Guidelines, in addition with Dr. Rhonda Bell. She published the menu plan and recipe book, Pure Prairie Eating Plan, to assist people with diabetes to stick to a healthy diet. Kathy Dmytruk, registered dietitian and certified diabetes educator, is the senior consultant with the Medicine Program Improvement and Integration Network, Alberta Health Services. As former senior advisor with the Diabetes, Obesity, and Nutrition Strategic Clinical Network of Alberta Health Services, from 2013 to 2024, she led the development of the diabetes foot care and eye care clinical pathways. Kathy has led several other diabetes and obesity initiatives over the years, including the Virtual Diabetes Prevention Pilot Program and the Bariatric Friendly Hospital Initiative. Kathy is currently leading diabetes improvement initiatives for the province within the new healthcare structure in the acute care organization. And with that, I will hand it over to Kathy Dmytruk.
Thank you very much for inviting us to speak today. I'll start our presentation and hand it over to Dr. Chan for the remaining half. So today we're talking about improving diabetes foot care in Alberta. And to start, I'd like to give an overview of diabetes in Alberta. Our learning objectives will be on the prevalence, health impacts, and cost of diabetic foot disease, the benefits of annual screening for diabetic foot disease, and how an initiative in Alberta cost-effectively increased screening. Currently, there's over 400,000 people, 9% of the population of Alberta, that have diabetes. This is from the Diabetes Canada Alberta National Backgrounder. And interesting, Alberta has the highest prevalence rate of all the provinces in Canada and has had the highest prevalence rate over the last 10 years. When you combine type 1, type 2 diagnosed, type 2 undiagnosed, and pre-diabetes, we're close to 1.3 million people in Alberta, which is 26% of our population. So it is definitely a rising concern of the rising prevalence of diabetes. Diabetes contributes to 30% of strokes, 40% of heart attacks, over half of kidney failure, and 70% of all non-traumatic leg amputations. We have measured this data in Alberta, and we are at 70%, which is in line with the Canadian numbers as well. The lifetime risk of developing a foot ulcer is as high as 34%. And the mortality rate after 5 years of a major amputation as high as 74%. So preventing diabetic foot ulcers is a critical step that we need to take to prevent these amputations and this high mortality rate following an amputation. But the good news is that 85% of ulcers are preventable. Just to give you a little bit of understanding of diabetes and how it leads to amputation, with the high blood sugars damaging the small vessels in the feet, eyes, and kidneys, with the microvascular complications, neuropathy can develop. And this is really a pivotal point where if we can catch people who have had loss of protective sensation in their feet, early signs of diabetic retinopathy, or kidney or nephropathy, this is really a sign to make sure that patients have their eyes checked, their kidneys checked, wear proper supportive footwear with a wide toe box, and examine their feet regularly to catch any problems early to prevent ulceration. As once an ulcer develops, there's a high reoccurrence of ulceration in the future. So once a patient has an ulcer, often it's referred to as an ulcer in remission, as it never completely goes back to the pre-ulcerative state. With the diabetes, obesity, nutrition, SCN, we were alerted that, foot care and not having a standardized approach to foot screening was an issue in Alberta. So we undertook the initial survey that we'll be talking about today to do an environmental scan of all those providers who care for people with foot problems and care for people with ulcers and amputations. And what we learned is really there was no standard approach to foot screening. A lot of folks said, we do foot screening, and when a patient is at high risk for an ulcer, has loss of protective sensation and neuropathy, there's nowhere to send them. There's good service once patients have an ulcer for ulcer care and wound care, but patients at risk of an ulcer really was a gap in our province. And there is still long wait for wound service, though. Therapeutic footwear policy, Alberta Aids to Daily Living does have a footwear program. However, all the prescribers for footwear were only located in wound clinics, and therefore patients who could receive footwear have had to have a wound already. Patients weren't able to access this benefit if they were at risk of a wound. So we got the experts together and we created a steering committee and a working group to look at developing a clinical pathway for diabetes foot care. We looked at developing screening and assessment standards, referral and transition processes. We developed a whole host of tools and educational resources for both patients and providers. And then to address that gap, of not having any services to refer patients who are at risk of an ulcer, we looked at the development of high-risk foot teams who would not only serve patients with wounds, but those at risk of a wound. This is a snapshot of the pathway that we developed. There's 5 steps, including screening, assessing the risk, triaging the risk, and referring the patient to the most appropriate provider to further assess, provide an intervention, and then have follow-up and screening guidelines depending on the risk level identified. We decided to develop a new screening tool as back in 2014 when we embarked on this project. There was the InLo tool, which was a validated tool, but providers said it was a bit cumbersome and that it had to be weighted. And so we developed a little bit of a more streamlined tool that we did compare against the InLo tool and validate it. Once the pathway was developed, to develop a communication and a dissemination strategy, we did a lot of engagement with primary care. Fortunately, we had some grant funding and we were able to put on 4 symposiums, 2 in June, 1 in Edmonton and Calgary, and then again in September in Edmonton and Calgary, and we had over 350 attendants at each symposiums. So our target audience was primary care nurses who do the screening in the primary care network setting. We also hired a clinical nurse educator to do education sessions, and we have still done those to date. Unfortunately, the SCN is no longer with the restructuring of the healthcare system, and we're not able to offer these sessions anymore, but we did build them electronically, and they are on our website where people can watch the modules. We did learn from primary care that it would be helpful to build the screening tools in their electronic medical records. So we partnered with the various vendors and completed that work over the last 4 years. And the tool is also in Connect Care. We reached out to Diabetes Canada, and we did do some patient awareness sessions through their patient forums that they hosted a few years ago. We created an insert for pharmacists to put in the prescription bag to remind patients to get their feet and eyes checked every year. We also partnered with the Diabetes Foundation, and they were very generous in funding equipment to high-risk foot teams. We've posted all the tools on our website, and as well as where the high-risk foot teams are. And we developed a geographic inventory of foot care nurses and partnered with the Canadian Foot Care Nurse Group to maintain that inventory over the years, which is also on our website. And by having high-risk foot teams who could see patients not only who had developed an ulcer but were at risk of an ulcer, we're able to now provide footwear for people before they have an ulcer through the AIDS to Daily Living program. This is just a sample of some of the tools that we have on our website that I've already mentioned, really helping primary care build foot screening into their workflows. We heard a lot from primary care that they only screened people who had an high A1C. They didn't understand the clinical practice guidelines recommend screening for everybody who has diabetes at least once a year. And by really embedding it into their workflows and not missing it and measuring it to make sure that they've done it, and setting up reminders in their electronic systems so that foot screening doesn't get missed. Now I'll hand it over to Dr. Kathy Chan to talk about the paper that we're here to talk about today.
Okay, so Kathy has outlined all of the actions that were undertaken to elevate screening for diabetic foot ulcer and then the aftercare. And of course, as evidence-based organizations, we wanted to know if having this pathway and providing all of this education had actually changed practice in the province. And so in 2019, we decided to do a follow-up to the environmental scan that had been conducted in 2014 and compare the answers and see what we could learn about changing practice. So this is the paper. It is open access on the internet, so anybody can read the full paper if they'd like to. And our aim was to assess the impact, as I said, of implementing the diabetic foot care clinical pathway and all of those resources and education that was provided to on organizational changes in diabetic foot care practices 5 years after initiating this whole big project. And the focus that was published in the paper was on low and moderate risk patients. And we hypothesized that in comparison with the responses that we received in 2014, we would find enhanced diabetic foot care practices, and particularly at sites with access to those high-risk foot teams. So it was quite a long survey. Some of you may have participated because we sent it out to everybody we could think of that had touched foot care in some way. So we looked at engagement in foot care related continuing education. So had people attended our symposia that Kathy mentioned, although I won't be reporting on that data today. We queried whether sites were offering foot screening, and then if yes, we dug down deeper to see what tool was being used, the setting that it was being used in, and the risk categories that were being seen. And then we also asked if there was a formalized foot clinic for assessment, and then if yes, what issues were being managed in the clinic and how often the patients were being reassessed. And so I'll be reporting on most of these data today. So who responded? In 2014 and 2019, the profile of respondees was about the same, although there were actually fewer respondents in 2019 than in 2014. But you can see most of the respondents were nurses or managers. And most of the responses came from primary health care, outpatient clinics, and home care. And that was also similar across the 2 years. In response to the question about whether foot screening was provided, it was 56% in 2014 and had significantly increased to 73% of the sites by 2019. And this assessment of moderate risk had also increased significantly over that 5-year period. So we looked at where screening had increased, and in particular, we saw that it had been quite notably enhanced in the North Zone and the Central Zone. And perhaps that makes sense, as Calgary and Edmonton Zone would have had the most resources for screening prior to implementing the foot care pathway. And so what areas of screening or what areas of practice did screening increase? Primary health care was notable. Wound clinics, also notable. So Kathy mentioned that prior to implementing the pathway, wound clinics saw people who already had wounds, but it seems that their catchment expanded a little bit after we implemented our pathway. And home care and long-term care sites also reported increased screening practices. And Kathy mentioned the development of our Alberta Health Services foot screening tool. So it was obviously not available in 2014, but 35% of the sites that responded to our 2019 survey said that they were using that particular tool. Okay, I think I'm going to skip this slide because I have most of the data in a nice graphic instead, but if you are looking at this presentation once it's been posted, you can see the tables as well as the graphics. So these, this particular data is looking at screening and assessment for moderate risk. And so you can see in panel A, which is on the left, that overall the screening behavior had increased as reported previously. There were more sites also assessing moderate risk. And although not statistically significant, there were also more sites on average that, or the proportion of respondents reporting that they assessed high risk had also increased over that time period. In terms of the different sites that were offering screening for moderate risk, we can see, or assessment of moderate risk, we can see it increased in primary health care. Sorry, this is for screening, not for assessing moderate risk. So this is panel B screening, so increased in primary health care settings and home care long-term care settings. This was statistically significant, but also a small uptick in outpatient clinics and community care settings that were performing screening. So again, I'm going to skip the table and jump right to the next two graphics. So we looked at what services were being provided in the settings where they had reported, or at the sites where they had reported assessment of moderate risk. And we divided these into 4 different types of services. So the first was nail and skin care services. And we can see a slight uptick there, but what was statistically significant was provision of a list of podiatrists to people who could use that service, as well as direct referral to podiatrists or foot care nurses. And you can also see that the high-risk foot teams had an impact, going from 0% to close to 40, about 30% of settings now referring to high-risk foot teams for nail and skin care services. And in terms of providing services for structural deformities, there was statistically increased provision of education, as well as referral to podiatrists or orthopedics. Then we looked at services for specialty footwear, which Kathy has alluded to, and there was nothing statistically significant in those data, but you can see that there were a few small increases, so increased education about specialty footwear and increased referral to services without necessarily using Alberta activities of daily living. And again, you can see the impact of the high-risk foot teams, where more than 40% of these settings reported referring individuals to a high-risk foot team so that they could access specialty footwear. So it was kind of a two-step process in that case. And then finally, sites looking, assessing vascular issues and peripheral artery disease in individuals at moderate risk. And once again, we can see that there were more sites that were performing vascular assessment. There were more sites referring to a physician for follow-up. And there was also, again, more than 40% of those responding reported that they referred to high-risk foot teams for follow-up. So overall, there was lots of good news. I think you've gone backwards there, Kath. Lots of good news in terms of increased uptake of screening and provision of services for people with moderate risk. So it seems like our efforts to increase foot screening and foot care for people impacted by diabetes had an effect at the organizational level, but of course we also want to know whether this initiative had an impact on patients. And so we don't have any data that is directly asking patients, and we don't have a lot of data about ulcer prevalence, but we did conduct a economic impact analysis. And I wasn't involved in this study, but I'm going to report to you what the results were. So it was a return on investment study and involved a retrospective cohort design in which two groups of patients were compared, those who had undergone foot screening and then appropriate follow-up through the pathway, which was about 2,400 patients, versus patients who had not had any foot screening. And they looked for reductions in health services utilization and found that there were statistically significant reductions in the number of hospitalizations of those individuals. When they were hospitalized, there was a reduction in the length of stay. There was also a reduction in outpatient visits and a reduction in visits to both their GP and specialists. So while that's not a direct measure of an impact on the patient, coming from the patient perspective, we anticipate that if individuals are utilizing less healthcare, then they must be having better outcomes. The return on investment of these avoided services amounted to $3,500 per patient per year. 85% of this cost savings was attributed to avoidance of hospital admissions, about 15% to decreased physician visits, and about 7.5% to decreased outpatient visits. So interestingly, CIHI recently published a document about amputations, which they titled Amputation Signal Opportunities to Improve Diabetes Care and Reduce System Costs. And they reported in that document that people who had received an amputation, 86% had both diabetes and peripheral arterial disease. The median length of stay was 19 days, and 15% of these hospitalizations involved more than one amputation, so more than one toe, for example. 43% of amputations were in people with diabetes who were still in that relatively young and working age category of 40 to 64 years. And so the impact on these individuals' family life, earning capacity, and contributions to society is clearly significantly impacted by these amputations. And of course, this was more prevalent in people with type 1 diabetes who usually will have been diagnosed at a younger age. So to conclude, we found, we hope that you appreciate that diabetic foot disease is costly to patients, their families, society, and the health system. But through provision of training to healthcare professionals and following a foot care pathway, we can improve screening rates, and that in turn will lead to increased capacity to provide care for moderate risk feet, reduce healthcare utilization, and ultimately for the patients, save their limbs and their lives. So I think that concludes our presentation today, but we should have lots of time for questions if there are any.
So I'm going to pop back in. So if anybody has a question, feel free to jump in.
So there is a question in the chat. It's from you, Rhonda.
Yep.
If you want to just go ahead and read it.
Sure. No, I'm impressed with the study. I was involved with the foot care program many years ago when I started my career. So I wanted to know kind of what the change in outcome or uptake has been with healthcare professionals since the study. Has there been a change of practice?
Yeah, I can answer that one. Again, we did do one other survey to PCNs in 2019 as well to try to assess this. There isn't a great mechanism to communicate with primary care, unfortunately. So we had to do a lot of engagement and partnering through our team. But definitely that survey did report that there was a great increase in awareness of the pathway, using the pathway tools. I did track, all the education we did, and we pretty much hit every primary care network with an education session over the last, well, it's been 10 years now. We also did presentations through the First Nations telehealth system twice and had quite good engagement from Indigenous communities as well. We've presented to home care and quite a bit interest from community pharmacists, actually. So community pharmacists are now using the foot screening tool and the pathway to refer patients, which is great. So yeah, I do feel that we've done a good job at our reach of primary care and community providers in doing foot screening, and definitely raised awareness. I think we can still do more with patient awareness, but again, unfortunately, Diabetes Canada, with like everyone else with financial restraints, hasn't done the patient forums like they used to do every year, where quite a few people with diabetes would come out for education sessions. So again, just any opportunities we have to provide education to patients is critical. And yes, the foot screening tool on Connect Care is used for any clinician who would like to use it, and it doesn't necessarily have to be for diabetes either if you want to do a foot screen on another patient population. We just recently upgraded and put a macro in so that with one click, if the foot screen is normal, you can enable that macro and then go in and adjust it so that you're not going through each field. I'm going to just be honest, the tool within the capability of what Connect Care was able to do, it is a little bit cumbersome to use, but it is there, and you are able to do the neuropathy assessment and outline which sites have loss of sensation, etc. So they did the best they could with the technology they had.
Okay. Are there any other questions? Feel free to come off mute and ask the questions verbally if you like. I don't see any more in the chat.
I could just make one more comment of some data that we didn't talk about today. We do have a dashboard that has been set up by Alberta Health Services Data and Analytics Group to look at amputation rates. And we have seen a trend of more, which also the CIHI report mentioned as well across the country, a movement of more minor amputations, ankle and below, and less major amputations of ankle and above. Especially we've seen this in the province, in the South Zone, in the Calgary area. In Calgary, there is a limb preservation clinic where they've integrated podiatric surgeons, endocrinology, vascular surgeons, nursing, dietitian in a very interdisciplinary team, and it seems to be making an impact on definitely decreasing the need for major amputations, which is significant because the higher up on the limb, the higher the mortality rate is after an amputation. So in 2024, I was involved with a working group to develop a vascular pathway. So for those of you who aren't familiar, if you just Google Provincial Pathway Hub, there is a hub of all the clinical pathways that have been developed in the province, and the new vascular pathway is there, which helps then get the patient to vascular services in a more timely manner, which is critical to help one heal the wound or improve vascular function to prevent the wound in the first place.
Okay, and we have a follow-up question to the Connect Care question. Is there a link from the Connect Care tool to the decision-making pathway referral guideline?
Yes, I believe there is, with the link to the pathway in the diabetes section of Connect Care. I can follow up and send that to you, Rhonda, if not, but definitely. But all our pathway tools are at www.ahs.ca/footcare. Footcare being one word, but even if you just Google DON-SCN, which is our former strategic clinical network, you can get to the pathway tools from that from there as well.
Okay, I can follow up with you and get those links and include them with the recording. Okay, any other questions?
Maybe I'll just comment that if we were to do further work, I think the Indigenous population is at very high risk, probably double the risk of the non-Indigenous population for diabetic foot ulcer, and also has generally less access to services. And so, you know, if we ever can get back to some of this work, that in my mind should be something that we prioritize.
Mm-hmm.
My earlier work, I worked with Boyle Macaulay, and that's where I had a large staff of foot care practitioners, just for prevention. So we had a foot care program there that you know, and a lot of walking, right? Like their feet are their transportation. And,
that's excellent, Rhonda. Thank you for, I used to do diabetes education at Boyle Macaulay many years ago as well, and definitely such a high need. I think Kai in the report, they did mention how the marginalized populations are the ones with the higher mortality rate after amputation, for sure. In Calgary, research, Dr. David Campbell has developed a mobile diabetes unit, and I've worked with his master's student to refer her to get training to do foot care, and so now she's going around on the bus and doing foot care and prevention, and they also are trained with the retinal camera, so doing some really good work to the vulnerable populations in that community. So
that's excellent.
Yeah, I'm hoping with the new primary care organization being stood up that this work can be revised or be revitalized again. Right now, my position has been moved to the acute care organization, so I'm focused more on diabetes specialty care at the current moment. But this work is near and dear to my heart, and I feel very passionate about prevention of diabetes complications, and hopefully the tools can stay on our legacy website, and I am around to answer any questions or give linkages or be a connector in any way to those of you listening today.
Okay, well, I don't see any other questions in the chat or hands raised. So I want to thank everybody for attending on this World Diabetes Day, and I want to thank Kathy Dmytruk and Dr. Catherine Chan for sharing their wisdom with us today. And I will send out an evaluation immediately following this, and we invite you to complete it.
Thanks, everyone.
Thank you. Thank you for having us.